So I was charged with talking about biologics, past, present, and future, and I hope to show you some ideas we've been thinking about and maybe generate some controversy for the panel discussion later. So this is the design of all the clinical trials, or the vast majority of clinical trials that have taken place so far. We start out with a flare. Not sure how to use the pointer here, but anyway, a flare, and then patients are randomized to placebo or experimental therapeutic. And then we add on standard of care therapies and then look for a renal response at some point down the road. These are the trials, just some examples in which this has been done. And to carry on with what Greg was talking about, these are the results. Here's all the drugs. Failed, stopped and failed, stopped, and these two are currently underway. So the success rate has been rather limited so far. And we try to explain these failures so we can understand maybe what to do differently. The drugs don't work well in lupus nephritis, and I think that's probably not the case, at least in most of the trials when pharmacodynamic parameters are looked at. B cells go down. In the LUNAR trial, double-stranded DNA went down, complement levels increased. So the kinds of things that we would hope would happen serologically do. And it seems like the targets are actually engaged. So that probably isn't what's going on. The other possibility is standard of care therapies are really so good that any effect of a novel drug is obscured. So I do want to discuss that a little bit. And then I want to spend a little bit of time on this. The expectations for these drugs are not actually matching their mechanism of action. And that goes to a little bit of what Greg said. Are we looking at the right outcomes, and are we using these drugs as effectively as they could be used? So if you talk about standard of care regimens in lupus nephritis and you say, well, how do they really do? I compiled results from many of the currently completed trials looking at the complete renal response rate at 12 months in the placebo arm. So this is standard of care plus nothing. And you can see here it's quite variable, but maybe comes out to about 25% of the patients have a complete renal response after a year of therapy using cyclophosphamide or MMF plus high-dose corticosteroids. So I would suggest to you that the standard of care therapy does leave significant room for improvement, and it isn't that we're obscuring the effects of the novel therapies. What are the consequences of not achieving a complete renal response in patients with lupus nephritis? This is an older study based on the plasmapheresis trial. Patients followed up over a long period of time. And I'll draw your attention, this is complete responders, partial responders, and non-responders. So I think we'll all agree if you don't respond with lupus nephritis, it's a bad thing. But a lot of people are satisfied with a partial renal response. And if you look here, compared to the patients who had a complete renal response, over the long term, patients who achieve only a partial renal response have a several-fold increase in end-stage kidney disease needing dialysis or transplantation. So I would suggest that's an unacceptable outcome. And also, the rate of moderate to severe renal flares is quite a bit higher in the partial responders, and of course, the number of flares does correlate eventually with chronic kidney damage and end-stage renal disease. So how would I interpret these data, or these compilation of data? If a novel therapy actually synergized with or targeted a different pathway than the standard of care, I think the complete response rates could be improved. Okay, so that's one hypothesis. Now, I do want to make a little bit of a caveat about use of standard of care therapies that I do think kind of mucks up a lot of our clinical trials in lupus nephritis, especially the so-called induction trials where patients have a flare and they're treated and responses are examined at 6 to 12 months. And I want to use the ocrelizumab story. So this is a Genentech product. It was a next-generation humanized anti-CD20. And it was in the BELONG trial. This was the BELONG trial. So 2 different doses of ocrelizumab versus placebo were given over a period of a year. This was in active class 3 or 4 lupus plus or minus class 5. And it was a failed trial, but if you actually then, in a post hoc analysis, broke the patients down into patients who had received large or small doses of methylprednisolone, you can see that the ocrelizumab actually did show some improvement. The ocrelizumab group had improvement in the renal response rate at 1 year if you received less than 500 milligrams of corticosteroid intravenously. So I do think that high-dose corticosteroids may actually interfere, and we need to start thinking about designing trials in which we can reduce the dose of steroids, which the community has been reluctant to do. Okay, what about the present? Well, I do want to talk about the rituximab trial, which Greg introduced. This is a trial that is not yet enrolling in the United States, but is about to. It started enrolling, I believe its first patient was 2 weeks ago in Europe. And this is class 3, 4, or 5 lupus nephritis. This is a rituximab arm, and this is a placebo arm. This is really a misnomer. It's not steroid-free. It's oral steroid-free. So the way this starts out is everybody gets methylprednisolone, 500 milligrams, day 1 and 15. And then they're randomized to getting rituximab and no further steroids, or else prednisone plus MMF. And of course, MMF is in this arm as well. And we're going to look at complete response rate at week 52. It's a non-inferiority trial. There is significant preliminary data already from the Hammersmith Hospital in England, where this has been piloted as a single center. And you can see this is complete and partial remissions in class 3, 4, and 5. They had a good rate of remission, similar to historical controls, and the mean time to remission was about 9 months, and that's similar to what we see in standard of care. So you could say, well, is that getting us forward? And I think it is getting us forward, and I'll switch to this side now to be equal. Some novel therapies may be able to substitute for corticosteroids, and even if they don't improve what we see in terms of complete response rates, I think eliminating or significantly reducing the corticosteroid would be a huge step forward for our patients with lupus and lupus nephritis. Okay. This is the hypothesis that I've been trying to sell to the companies and to trialists as we move forward in designing clinical trials. And I would suggest the therapeutic expectations of the novel therapies that we've tested to date have not really been appropriately matched to the phase of the LN flare cycle based on their mechanism of action. So that's a bunch of words. What do I mean? This is my wheel of lupus. Some people like it, other people tell me they hate it, but you're stuck with me today. So you have a genetic predisposition and environmental factors triggering systemic autoimmunity. It's activated. And it would be wonderful if we knew when that was happening or could pick these patients out, but let's say we don't, because we don't right now, and you have subclinical kidney injury. So all of this is occurring, and we don't know it. And I think we all understand that. This would be a wonderful time to intervene with a lot of our therapies that attack autoimmunity, but we just don't know how to predict this yet, although that is something that people are working on. So we get lupus nephritis when it's clinically apparent. Proteinuria, hematuria, edema, renal insufficiency. Something draws it to our attention. We do a kidney biopsy, hopefully. At this point, when you see lupus nephritis, and I'm speaking particularly of proliferative lupus nephritis, this is an inflammatory disease, and we should be targeting inflammation. And I want to talk about some of these therapies that we really might be able to test in this way. So target inflammation. Then we have clinical improvement. We want to keep the patient in remission, but at the same time that this is occurring, renal autoimmunity is still going on. Target now using some of your novel therapies against B cells, T cells, and interferon, and use these as maintenance therapies. So this is a lot different than the way we've approached this so far. So what about targeting inflammation? Well, the reason corticosteroids work so well is that they're profoundly good anti-inflammatory drugs. And as you know from the early NIH trials, it wasn't the cyclophosphamide or the addition of an immunosuppressive didn't help early on, or I shouldn't say it didn't help. Steroids were as effective as steroids plus cyclophosphamide early on. It was in the long term that cyclophosphamide prevented flares and maintained renal function over the long term, and it took 3 to 5 years to see that. So this is why I think corticosteroids are so effective early on. But we should think about complement inhibitors, cytokine inhibitors, and maybe even NF-kappa B inhibitors. And NF-kappa B, of course, is a transcription factor that turns on a lot of pro-inflammatory cytokines. And this would be my first choice in treating patients for induction of lupus nephritis. So, just to show you, standard of care therapy does not always resolve glomerular inflammation. These were older studies done by a nephropathologist, but if you had a residual crescents or necrosis 6 months after induction therapy in a repeat biopsy study, these were the people who overwhelmingly went on to double their serum creatinine at 5 years. For nephrologists, doubling of the serum creatinine is a surrogate marker accepted by the FDA of end-stage renal disease in the future. Okay, and you can see this, they used a biopsy inflammation index, so if it was less than this value, the values don't matter, this biopsy inflammation index considers both glomerular inflammation and interstitial inflammation. If you resolve your inflammation, you do well. If you don't resolve your inflammation after standard of care therapy, you don't do well. So, are there things we can add to induction therapy that might synergize with corticosteroids to help reduce renal inflammation? And I know this conference is on biologics, but this is a small molecule, so I kind of throw them in the same grouping, the novel therapy. And laquinimod is an oral immunomodulatory agent. It's being developed, had been developed, now it's not for lupus nephritis, unfortunately, but they're focusing more on neurologic disease. It reduces NF-kappa B activity, it reduces pro-inflammatory cytokines, leukocyte infiltration, and modulates T-cell responses. And this has been shown in models of autoimmune encephalitis and also in models of murine models of lupus nephritis. We recently completed a phase 2 trial. Here's the design of the trial. Steroids, this was IV steroids, then MMF plus an oral steroid taper, placebo, and 2 different doses of laquinimod. Now, this was mostly a safety and tolerability study, so it wasn't powered appropriately, but you can see here the improvement in the GFR, the estimated GFR, was more in the patients who had received the laquinimod, and the decline in proteinuria at 6 months was greater in the patients who had received the laquinimod. So it seems like this can synergize with the anti-inflammatory action of corticosteroids and perhaps provide additional benefit in an induction trial. I think this is worth repeating. The company doesn't, so end of the story. But we are trying to work with the company to take this outside of neurologic disease. Other currently usable anti-inflammatory approaches that we should consider are complement. As you all know, there's a C5 antibody, C5a antibody out there that's used for a variety of diseases, not trialed yet in lupus nephritis, but old data using the same formulation in a murine model of lupus nephritis shows that these are mice with significant proteinuria. These are untreated or using a control antibody. These are mice treated with the anti-C5, and this is survival of the mice treated with the anti-C5. And if you actually look at the tissue, you can see that these mice have far less glomerular inflammation after being treated with the C5 antibody. I'm going to throw one other thing that I don't have on the slide because Greg mentioned it, the proteasome inhibitors. Not only do they kill B cells making the autoantibodies, but they actually work by inhibiting NF-kappa B. So you might get 2 bangs for your buck if you use a proteasome inhibitor, and we really had a very nice one, carfilizumab, that we were bringing to trial. FDA allowed us to go forward with it, then the company was bought, and that's the end of that one. So there's been some unfortunate history in the biologics. Okay, so let's say you control the inflammation early on. Then you target autoimmunity, and I would say you can target the autoimmunity at the same time that you're targeting the inflammation. And you would use B-cell modulators, T-cell modulators, and this is where I think these therapies would have a role in maintenance. Okay, and so the reason they haven't worked, in my opinion, is that we've been using them for induction, and they're not induction drugs. They're not going to increase complete renal responses, and so what we're looking for them to do at the end of 6 months or 12 months is not matching what they actually do. Do I have any data to support this, or am I crazy, like the ad boards think? So if you actually look at BLISS, which was the two large BLISS trials, which were not renal, okay, but they had patients who had lupus nephritis that was quiescent, and of course they had lots of lupus patients that would potentially go on to have renal disease. A post hoc analysis was done by Marianne Dooley. She compared the rate of renal flare in patients receiving placebo to the patients receiving the two different doses of belimumab, and you can see there's a dose-dependent decline in the renal flare rate in these patients, suggesting that the patients who received belimumab may have been maintained better than the patients who had received placebo. What about a little stronger evidence? This is the abatacept trial. I'm not going to discuss this for time's sake, but it's CTLA-4 Ig. It's a co-stimulatory blocker, so it's an anti-T cell drug, at least on the surface. And this was the design of the ITN abatacept trial. This was recently published in A&R. I think that got cut off here. But in any case, it's not too dissimilar to the trial that was from BMS with abatacept. And the bottom line is, at the end of 6 months, there was no difference in complete or complete plus partial response, adding abatacept to standard of care or using placebo. Okay, so it didn't work during induction. But this trial had a very interesting component to it. If you achieved complete renal remission at 6 months, in the abatacept group, everything got stopped. Now, I don't think a single person in this room would stop everything at 6 months in a lupus nephritis patient, but this was part of the protocol, and we did this at our center too. Everything was stopped, and then it was compared to patients who had received placebo, and then they continued with azathioprine. You might say, well, we don't use azathioprine very much. This was low-dose cyclophosphamide as standard of care, the Euro-Lupus protocol followed by azathioprine. So we tried to keep everything consistent. And then we followed these patients up at a year. And what it turned out was that the complete renal response was maintained as well in the patients on no further immunosuppressive medication as on the patients with azathioprine. Okay? No medication, maintenance of renal response. New flares, both renal and non-renal, and I realize these numbers are very small. We can criticize this. And of course, this isn't statistically significant, but the number of new flares was about 3-fold higher in the group on maintenance immunosuppressive drugs, suggesting the possibility that the CTLA-4 Ig could be used as a maintenance therapy. Okay, the future. So Greg showed you the future of some of the drugs in the pipeline. I want to show you something a little bit different. This is some of the things we're doing in our lab, just very briefly. And what I want to get at is possibly making more out of the kidney biopsy than the simple histology that we all are used to seeing. And that would be a molecular approach to targeting drugs to patients with lupus nephritis, which we could then use towards perhaps personalizing these therapies and getting them with the correct patients. So we've been doing studies with collaborators in South America. Lupus nephritis, there's a biopsy, they get induction therapy, there's another biopsy, and we're doing omic evaluation. We can then determine the molecular changes that occur in complete responders and the molecular changes that occur in non-responders. I don't think we know this information. We don't really understand what happens in the kidney in response to therapy in people who get better or don't get better. And then maybe we can identify some targets that might be interesting. So we did this, and I've got a short time, so I'm just summarizing a bunch of data. These are differentially expressed genes in the serial biopsies of complete and non-responders. So a complete renal responder is defined in the usual way at 6 months that we talk about: a decline in proteinuria to a certain level, stabilization of the creatinine, et cetera. And a non-responder is somebody whose proteinuria did not improve and or got worse, and the creatinine did not improve and or got worse. And if you look at complete versus no response, and I've highlighted, these are 7 genes that are differentially expressed in the complete responders versus the non-responders. NCAM1 is an interesting adhesion molecule. It's a neural cellular adhesion molecule, but it's found in the kidney, and it may actually be related to repair of the tubules. Interestingly, this is way upregulated in the complete responders versus the non-responders. So that's interesting, right? These people are repairing their kidney, the non-responders aren't. What I wanted to point out was IL-17A. This is markedly reduced. Its expression is markedly reduced in the kidney of responders compared to non-responders. So the patients who didn't get better with standard of care therapy, there's no novel therapies here, did not turn off their IL-17 signal in their kidney. And of course, there are drugs that target IL-17 now, biologics and monoclonal antibodies, that I believe have changed the management of psoriasis, and some of these drugs will now be trialed in lupus nephritis. So to conclude, we've had fairly disappointing novel biologic trials so far in lupus nephritis. I don't think it's because the biologic is not effective against the target. I think they are effective against their target. I think that we're not matching what we want the biologic to do to the best point of its action in the flare cycle. And if we do that, we might improve the outcomes by looking at these things a little bit differently. And I also understand that maintenance trials are a lot harder to do than induction trials and take longer and therefore are more expensive. High-dose corticosteroids really may confound trial interpretation and results because they're so effective as in anti-inflammation early on. So we have to think about that as we design these trials going down the road. And I think we can get a lot more information from kidney biopsies at the molecular level that we can use to design drugs or to place patients into clinical trials with the appropriate sorts of therapies. Thank you.